College of Pathologists, United Kingdom. And she has worked in renowned centers like SRL Diagnostics and Sir Hiranandani Reliance Foundation Hospital before moving to England in 2019. So she is presently working with Catedral and Huddersfield NSH Foundation Trust as a consultant histopathology. So for this short introduction, I would like to invite Dr. Prisha Balan to share her expertise. And welcome, Dr. Prisha, and your mic is now in your hand. Thank you.
Thank you very much for the kind words. I'm sorry for the hassle in the beginning. Just to give you an introduction, so basically histopathology is a very specialized branch of pathology, and not many people, including doctors, know what exactly happens in a histopathology lab.
भैया आपको कुछ काम है क्या यहाँ पे? जल्दी से लेके जाइए.
Sorry, yeah. So basically, even not many people know what happens in a histopathology laboratory, even including doctors. So I really think it's a very good opportunity for me to to explain what exactly happens in the lab, and letting people know what happens in the histopathology laboratory specifically, and what role a histopathologist plays in the treatment of patients, mainly cancer patients and all those things specifically. So I'll just start sharing my screen. So where is that option? Just a minute. Yeah, share screen. Give me a minute. I'll.
No problem. No problem.
Because I need to transfer that from the main device to this device now. Yeah, can you see my presentation now?
Yes, we can see.
Yeah. Yeah, so start with the insights to histopathological practice. So initially, I would like to start with who is a pathologist. So with this COVID going on nowadays, so many of us would be knowing what a laboratory is and what important role the laboratory plays in patient in diagnosis of diseases and patient management. So I will just start with a small video which shows what exactly happens in a laboratory and what the different kinds of pathologists are. Yeah, so just to give you an overview, so there are different types of pathologists, and so what I do is basically histopathology, which mainly deals with tissue diagnosis and further management based upon that. So basically, pathology is a science which deals with the causes and effects of diseases, and histopathology specifically is a branch of medicine that deals with the laboratory examination of samples of body tissue for diagnostic or forensic purposes. So what happens in a pathology department? So basically in a pathology department, there are teams of doctors and scientists whose job is to study the samples from a person's body to understand what's making them unwell. So this team is basically made up of a pathologist who is a doctor with specialist laboratory training and supportive biomedical scientists and other support staff, which includes people who are sitting at the reception who receive the samples, which the wards send to the lab, people who are involved in transferring samples from one part of the department to the other, people who are involved in cleaning and other services in the lab, and also IT support staff. So doctors, nurses, surgeons, and other medical staff look upon to pathologists for advice on the nature and seriousness of a patient's illness, making sure they get the most appropriate treatment. So the main points which I'm going to discuss in this presentation today is initially macroscopic pathology, which involves examination of the specimen with the naked eye. So what happens exactly, just to give you an overview of what happens is basically if there is a lump in the body, or which can be seen either externally, if you have a lump on the hand or the leg, which you can see externally, or if you feel a lump inside the body, like within the breast or within the abdomen. And if somebody goes to the doctor, mainly to a surgeon, the surgeon examines the patient and either takes a small portion of a tissue from that specific lump and sends it to the laboratory for diagnosing what it is exactly. Or if he thinks that it has to be removed, he removes the whole lump and sends it to the laboratory. So what we do as pathologists is look at this specimen grossly. That is the initial step for the examination of the specimen. That is known as macroscopic examination, which means examination of that specimen with the naked eye. The next step is processing of the tissue. So when we look at the specimen, we take samples from areas which we think are abnormal in that specimen, and those samples are processed. It is a 17 to 18 hour procedure when the small piece of tissue is converted into a paraffin block, a block which is made up of wax, and the tissue is embedded in it. I will show you exactly how it happens. And from that block, very thin sections are taken on a slide, and which is stained later on, and it is visualized under a microscope. I know it's difficult to understand what exactly is happening here, but I will take you through this step by step. The next thing which I will discuss is about cytology. So if histopathology involves examination of a piece of tissue, cytology involves examination of individual cells of the body. So if you have a lump, the surgeon or basically any clinician can just poke a needle into that and take out some cells and put it on and send it to us, and we can again stain it and see it under the microscope. So this only involves cells in place of the whole tissue. Next, I will speak a few words about frozen section. This is an interesting part of pathology where the specimen comes to the pathologist directly from the operation theater. This is done when surgeons want an emergency diagnosis, they want an immediate diagnosis, and the tissue is sent to the laboratory from the surgeon, and we examine the tissue over a period of 10 to 20 minutes, and the report is informed on the telephone. Is something coming up on the screen? Hello, can you hear me? Can you hear me?
Hello, we can hear you, madam.
Yeah, okay.
Yes.
Yeah. And the next thing I would talk about is immunohistochemistry. I will describe what exactly happens in that, followed by molecular pathology and digital pathology. So before I go into histopathology completely, I would like you to understand a few terminologies. So this is the basic page of textbook of pathology for a first year student. So first, the thing which you see on the left is how normal cells look like. So if you see this one, a normal cell, which is each cell is of equal size. The central part is the nucleus, and it is surrounded by the cytoplasm, and everything looks the same. Each cell is similar to the other one. So if you come to the next one, it is known as atrophy. In atrophy, basically how like when we grow old, when we become older, our body shrinks in size. So what exactly happens here is the cells become smaller in size, the nucleus and the cytoplasm all become small in size. Like if you have a fractured hand, and if the hand is kept in a cast for a long time, you will see that the muscles have become smaller in size. That is known as disuse atrophy. Because there is no use of the muscle cells tend to shrink in size. So that is known as atrophy. Next thing which you see is hyperplasia. In hyperplasia, what exactly happens is there is increase in the number of cells. So instead of 4 cells, where there should be 4 cells, there will be 8 cells, but each of them will still be normal. It is just that it increases in number. That is known as hyperplasia. Then this is hypertrophy. Hypertrophy is basically when the cells increase in size. So when does this happen? The most common example is when people go to the gym and when they do bodybuilding. So what exactly happens is their muscles increase in size. When it increases in size, what happens at the cellular level is the cells increase in size. Each cell increases in size, it builds up together and gives to increased muscle mass. That is known as hypertrophy. The next one which you see is metaplasia. Metaplasia is is a case when one set of mature differentiated normal cells changes into another kind of cells. So like how we have on our skin is made up of squamous epithelium, that is a mature differentiated cell. So when one kind of epithelium changes into another kind of epithelium, like in the trachea and in the respiratory tract, it is lined by different kind of cells known as pseudostratified ciliated epithelium. So this is respiratory epithelium. So when one kind of epithelium changes into another kind, it is known as metaplasia. This is also a normal process. It is seen in many parts of our body as response to irritation. Any kind of irritation which occurs in the body responds by changing into another kind of epithelium, which acts as a better protective mechanism. So these are all normal phenomena. The bottom two things are the abnormal stuff. So if you see dysplasia is these two are normal cells. When they look normal, they look similar to each other. But if you see this here, there is a clump of cells here which look different. Each cell is of different size, each cell is of different shape, and the nucleus and the cytoplasm all look different. But still the cells are limited by a limiting membrane here. They have not gone beyond this. So this is considered to be a precancerous condition that is known as dysplasia. When these dysplastic cells become more, they increase in number, they increase in size, and when they break the limiting membrane and infiltrate into the underlying tissue, it becomes cancer. So this is the basic way a cancer develops. There is a precancerous condition which progresses if left unchecked, and it goes into a cancerous condition. So there are many reasons why this happens. There are underlying genetic mutations. There are mutations which occur otherwise externally. And I will not go into the details of all that, but it is just, I just wanted to show how cells look different in the body. So this is a graphical representation. So what I will do now is, like in the laboratory, we receive innumerable specimens from head to toe. There are many specimens which come to us, small and big both. So I have chosen breast resection specimen. I will take you through this step by step, how we examine the tissue, what exactly happens in the laboratory. Each organ in the body has a different protocol of examination, different protocol from where sections need to be taken, and different kind of cancers and different kinds of management. But I will take you through how we deal with the breast resection specimen. So as I said, first I will talk about the gross pathology. Gross pathology is what we see with our own eyes. So this is a specimen which comes to the laboratory. This is a breast resection specimen where this is the skin of the patient. And I want you to imagine how the specimen would be in the patient's body. So this would be the skin of the patient, and this is the tissue, the breast tissue, where the surgeon might have detected the presence of a tumor. And this is the axillary tail. Axillary tail is the part of the tissue which is under the armpit. So this area contains a lot of lymph nodes, which is basically the job of these lymph nodes is to drain the tissue, drain the breast tissue and the surrounding area, which is a normal process in the body. So when there is cancer in the breast, the lymph nodes will tend to drain the cancerous cells also, and the lymph nodes will carry them along with that. And this will lead to higher staging because it has gone into a node. So basically what the surgeon does is remove the tumor along with the organ and the adjacent axillary tail of fat. So now you will wonder why there are so many colors here. So what the job of the pathologist is when you cut the specimen, you look for the tumor, and mainly what we need to do is tell the surgeon how far the tumor is from the margins of the tissue. So this is the superior margin, this is the inferior margin, that is the top and the bottom. So when you turn the specimen around, this is how it looks posteriorly, that is behind. This is the medial side and the lateral side. But how do we know? Under the microscope, they will all look the same because it is all fat. So when you cut sections and when you put it under the microscope, you will not understand which part is which margin. So what we do as pathologists is we ink each of the margins with a different color of ink. So each hospital has a different coding system for this. So we use the superior margin as one color, inferior margin as one color, medial, lateral, posterior with different colors. So what we do is we will, when we sample it separately and we see under the microscope, we will see there is a tumor and that how much distance the tumor has from the margin, and we can give the exact margin to the surgeon. What is the importance of this margin? So for the surgeon, what he wants is complete removal of the tumor. He doesn't want any tumor to remain in the patient's body. So if we can tell him that this margin, this margin, this margin, this margin, and the margin behind, where the tissue is connected to the patient's body doesn't show presence of tumor, it is assumed that there is no tumor which remains in the patient's body. So that's why it is important to evaluate all the margins carefully. If there is tumor within the patient's body, if the margins are positive for tumor, that's how we call it. That means the surgeon needs to go back and remove more tissue so that there is no remaining tumor in the body. So how do we know what exactly a tumor looks like? So if you look at this picture carefully, I don't know how much you'll be able to appreciate, but this is the normal tissue. This is how the normal breast tissue looks like. It looks like a plain fatty yellowish thing. And if you see this area, it looks different. It is whitish and it is irregular here. The margins, if you see, it is irregular. And if you feel this, if you can feel this, it is very hard than the normal tissue. The normal tissue will be soft, but this will be very hard. It will be more like you are touching a piece of wood or something in the tissue. So that is how a tumor looks like. It is not very easy. Most of the times you can look at the tumor and say it is tumor, but many a times when the patient has received prior chemotherapy or when there has been some other procedure before that, there'll be many firm areas, many different feeling areas, and only with experience you would be able to say whether this is tumor or not. This might be tumor, and you might need to sample that area. So what is the importance of understanding this? So basically, in pathology, what we do is like we examine the specimen and we will give them the tumor size. So the tumor size is basically measuring this area with a scale. So each organ has a different staging system. So this is known as a Tnm staging system. The Tnm staging system is basically we examine the specimen and there are many parameters which we take into account and give this staging. And based upon this staging, the clinician decides what treatment needs to be given because their protocols are based upon what stage the tumor belongs to. So to give you an example, if in a breast specimen, the tumor size is around 3 centimeter, it would be called a T2 stage. So if a tumor is less than 2 centimeter, it will be a T1, 2 to 4 will be T2, more than 4 will be T3. But as I said, each organ has a different TNM staging method. I'm just telling you about breast right now. What is N? N is basically involvement of the lymph nodes. As I told you earlier, in the axillary pad of fat, there are lymph nodes. So when you examine the tissue, you even sample those lymph nodes. And these lymph nodes, if they show presence of tumor, that is known as an N staging. So if there is involvement of lymph node, it will be called as N1. So that also, depending upon how many lymph nodes are involved, the N staging changes. And that will be high. As the number increases, the stage will be higher. And what is M stage? M stage is basically presence of distant metastasis. So if a tumor is seen in a site other than far away from the main site, so if in a patient with breast cancer, if you see a tumor in the liver, and if it is a metastasis, if you see a tumor in the liver, basically that tumor has spread from the breast to the liver, and that is known as a metastasis. So that makes it again a higher stage. Presence of metastasis basically is stage 4. So that is how you give the TNM staging to the surgeon. And that is, and based upon this staging, the surgeon decides what further management needs to be done, whether it is giving the patient additional chemotherapy, whether it is giving radiotherapy, or whether it needs going back and operating again. So all these things, there are clinical protocols to be followed based upon the staging system. So what kind of breast specimen do we receive in the lab? So we receive wide local excision. So when there is a small tumor, only a small part of the breast with the tumor is resected. And the surgeon makes sure that there is adequate margin, adequate normal tissue around this tumor so that it is clear of the tumor. The surgeon will not want to cut the tissue very close to the tumor where he will not have an adequate area of normal tissue and adequate area of clearance. Next, we receive mastectomy. These are the two most common type of breast specimens which we receive. The mastectomy, entire breast with the overlying skin and nipple is removed with the lymph nodes. That is the specimen which I showed you earlier. So as I said, what are the goals of crossing? It is to basically identify the specimen, determine its orientation, which side of the body the specimen belongs to, whether it is the left breast or the right breast, and the dimensions of the specimen. Identify the presence, the location, and the dimensions of the tumor. This is important because we need to know the margins. We need to know the tumor stage. Estimate the distance of the tumor from the resection margins, and to take representative sections for microscopic evaluation. So only on the basis of the presence of tumor, we cannot give a complete report. We need to tell the surgeon what tumor is it, what grade the tumor is, how many, there are many other parameters which we need to tell the surgeon about. So we need to look at the tumor under the microscope to know exactly what tumor is it. So within the breast itself, there are many different kinds of tumors. It is not that all the breast cancers are the same. So there are different kinds of tumors. Each tumor behaves differently. Each tumor has a different way of management. So as I showed you earlier, so if you see this specimen, and if this is a specimen which we have received. So what we do is we cut this specimen into serial slices. So each slice we will take a knife and we will cut it like this, like how we cut a piece of bread. It is known as bread loafing. So each slice is around 2 to 5 millimeter in thickness. So we cut it serially and we place it like this, how you can see in this picture, one after the other. And if you see this section here, so in this specimen, we have identified that the tumor is present in this area. So what we do is, so if you see here, this is the tumor here, it is firm and hard. It looks different from the normal tissue. And if you see here closely, you will see that this tumor is close to this margin here. So what we will try to do in this specimen is we will sample this area together so that we get this margin and this margin together. We can give the surgeon an appropriate distance of the tumor from this margin. Microscopic evaluation will be definitely more appropriate than what we see macroscopically. Under the microscope, we can measure exactly how much is the distance from the different margins here. So that is the most important thing which we need to do in this resection specimen. So how do we do it? How does this tissue reach the microscope, and how are we able to see it under the microscope? So what we do exactly is we take small sections and we place it into different containers. So these containers are known as tissue cassettes. So this is how it looks. So the next step, so after the process, the macroscopic examination of the specimen, the next step is tissue processing. So tissue processing is basically where a normal tissue which is taken from the body is converted into something known as a paraffin block, which you can see on the right side. So the paraffin block is from where we cut sections and use it to see under the microscope. So before I go to this, I just wanted to make one more point that when the specimen reaches the laboratory, you might be wondering, doesn't it get decomposed because it is human body? Human body tissue, doesn't it get decomposed? So what I didn't tell you about is what the specimens are sent to the laboratory in a specific chemical known as formaldehyde. So formaldehyde basically helps to preserve the tissue, and all the specimens in the histopathology laboratory are in containers which contain formaldehyde along with the tissue. So yeah, coming back to tissue processing. So when the specimen is cut into smaller pieces, it is put into these tissue cassettes, and these tissue cassettes are basically made to go through a overnight process. It's around 15 to 17 hours procedure, where these tissue cassettes are run through a machine known as a tissue processor. So what this tissue processor does is takes this tissue through different stages of dehydration. We use alcohol as a dehydrating agent. It takes away the water from the tissue, makes it into a hard tissue piece like this, and then it is put into a block known as a paraffin block. So I'll just show you how this works. Sorry.
Hello, madam. The audio is not coming. Voice is not coming of video.
Oh, okay. Is it coming now?
No.
Okay, so I'll just describe what's happening here. So basically the tissue is taken from the tissue cassette and it is put into the what that lady took in that mold is basically paraffin. It is melted wax and the tissue is taken from the cassette and put into that mold. And that is melted wax, which is hot. After the tissue is put into that, it is kept on a cold part so that it becomes hard. So you put more wax on that. And this is allowed to settle down and become hard because the temperature is low on that part of the machine. It will help it to solidify and become hard wax. Basically, they are checking whether the wax has become hard enough. When it becomes hard, it looks like that. And they separate it from the mold at the bottom like that. And that is the paraffin tissue block. So that's how the tissue block is made. So in a laboratory on a day-to-day basis, hundreds of tissue blocks are made because hundreds of tissue cassettes are taken. And each block is preserved and stored in the laboratory for many years because from one particular block, you can take many sections. So what happens is this is a machine known as a microtomy machine. So after the block is made, this block is fixed on this machine. And this part, which you can see here, this moves up and down. When you roll it, it moves up and down. And this is a blade here at the bottom. And this blade uses this to cut thin sections of this block. So these sections are very thin. It is around 5 micrometer in thickness. As you can see, they give out these ribbons. If you keep cutting, it comes out as a ribbon. And what they do is take it out with a fine brush and put it on a water bath. So this water bath is at a temperature which is around 2 to 3 degrees lower than the melting point of wax. So that this straightens up, it becomes a ribbon without any curls. And then you dip a slide in that and it is taken on the slide. So that is how the tissue which we sample reaches the slide. I know it's very difficult to understand because only if you see it happening, you understand how it becomes a slide like this. But basically what I wanted to understand is a big tissue is the important areas from a big tissue are sampled into smaller tissue pieces, and the smaller tissue pieces are converted into paraffin blocks. And from the paraffin block, thin ribbons are cut and taken on a slide. So after the slide is made, the human tissue is transparent. When we see our own body, it is not that we can see it in different colors. So you need to stain this tissue to see under the microscope. So when you stain the tissue, the slides look like this. This is in a histopathology laboratory, you will see trays and trays of slides with this color. So this is basically known as hematoxylin and eosin stain. This is the basic stain used in a histopathology lab. So basically what is staining? Staining is a technique which is used to enhance the contrast in samples. So any transparent thing, if you put some paint on it, you will see it better, isn't it? So that's what a stain does. So it is generally, stains and dyes are frequently used in histopathology. There are various kinds of stains, but hematoxylin and eosin is the basic stain which is used. So what does hematoxylin do? So these are two stains which are used. Hematoxylin gives the blue color to the nucleus. The nucleus which you see here, darker color, that is hematoxylin, and the pink color which you see is eosin. So these are all natural dyes which have been modified over a period of time. Over the number of years, these have been modified. The staining processes have been changed. Earlier, they were done manually. Now you have automatic staining machines. You just need to load a set of slides into the machine and it comes out stained and nice. So that's what it is. What you can see on the right is how a normal liver tissue looks like in the body. Each tissue in the human body looks different, and each tumor in the human body looks different. And that is what we as histopathologists do over the years to understand each of it and each of its pathologies. So coming back to breast again, so this is how a normal breast tissue looks like. So this is normal duct in the breast, and this is the normal stroma in the breast. So this is all nice and clean. All the cells look clean. All the cells look similar to each other. There is no change in the size and shape of the cell. But if you look on the right, this is how the tumor tissue looks like. Each cell looks different. Each cell is bad. Each cell is of different shape and sizes. The nucleus is bad. The nucleus, if you see, they are of different shapes and sizes. So that is how a tumor tissue looks like. So what we do as pathologists is identify whether it is normal or whether it is abnormal. So that's about histopathology. So as I described earlier, what basically histopathology is when you examine a piece of tissue under the microscope and give the surgeon a specific diagnosis. And especially in cancers, we give them the staging as well. There's one more thing I wanted to know, that histopathology is not only about cancer. We also do benign stuff. We also examine and tell that this is a normal tumor. This is not a harmful tumor. Like there are many benign tumors also which are not harmful to the patient. So it is basically differentiating between what is harmful and what is not harmful to the patient. So coming to the next topic, that is cytology. So this is known as fine needle aspiration cytology. As I described earlier, when histopathology says about describing about assessment of a piece of tissue, what cytology does is assessment of a few cells in the body. So if you see a lump in your hand, or if you see a lump in your neck, and you go to the doctor saying that there is a lump which is causing discomfort to me. So the surgeon can, it can be done anywhere. Most commonly it is nowadays done by the radiologists. Earlier days it was done by the surgeon, and in many centers the pathologists also do this. So what they do is you put a small needle into the lump and you move the needle to and fro. So what happens is, this is under negative suction, and when you move the needle to and fro, few cells of this lump will come into this syringe. It will come into this syringe through this needle. And what you do is take these cells, take them on a slide and spread them and stain them again and see them under the microscope. So again, based on this, you can give a diagnosis whether it is a benign tumor or whether it is a malignant tumor. The most common sites where FNAC is done nowadays is the thyroid gland, the lymph nodes. If you get swellings in the neck, it can be, you can easily put in a needle and see what it is, rather than going through a whole process of taking a biopsy and do it. The next most common site is the breast again. Again, if there is a big lump in the breast which the patient can feel, which the doctor can feel, they can just poke a needle in it, take a few cells, examine under the microscope, and give a diagnosis. So this is how a thyroid fine needle aspiration is performed. This is the thyroid gland here in the front of the neck. This is a needle, and this is a needle attached to a syringe, and this is a piston. This just makes the process a little easier. It is easier to kind of push the syringe and put negative suction and take the specimen like this. So this is, the needle has gone into the gland, and you can see that the doctor is aspirating the cells from the thyroid gland. So again, in cytology, there are different stains which are used. There are many different stains which are used in histopathology. These are the basic things which I'm telling you. So the most commonly used stains is the Papaniculaou stain. This is commonly known as the PAP stain. This is one of my favorite stains because it looks very nice under the microscope. As you can see, they are very bright and different colors, and basically for your, I can understand that for the person who sees these things for the first time, they all look the same. But over a period of time, you will come to know, like when you keep seeing these things, you can identify that this is a normal cell. This is a normal nucleus, a normal cell with normal cytoplasm. This is abnormal. This doesn't look good. The nuclear borders are not clear. They are irregular. It is big in size. It doesn't look good enough to be called normal. So each organ has a different kind of cells which come, and that is the job of the pathologist to identify and say whether it is good or bad. So this is one kind of stain. This is the PAP stain. The other kind of stain which is used in cytology is the GIMSA stain. This basically does the same job, but it is just that it is a different color, and there are finer points in it which I wouldn't go into it, but there are finer points. The PAP stain is basically done to look at the nuclear features better. The GIMSA is basically done to look at the cytoplasmic stains better. So that was a short description about cytology. Cytology is done in many labs, in many small labs, because it is an easy process, and the patient can be given the report over a period of 1 or 2 days, and we do not need many high profile equipments like how you need in histopathology for taking the tissue, processing the tissue, embedding and making it into a block, and you do not need a very big setup for cytology. It can be done at a basic lab over basic expenses only. Next, coming to frozen section. So frozen section is a very interesting part of pathology, and this again can be done only in higher centers. It requires the most important investment in this is a cryostat. It is a machine which maintains temperature, very low temperatures, around minus 20 degrees Celsius. So what, as I told earlier, what basically happens in frozen section diagnosis is the surgeon wants an immediate diagnosis. So it can be a primary diagnosis. The surgeon will remove a tumor from the body and would say, please tell me whether it is benign or whether it is malignant. Is it normal tissue or it is a tumor? So that, the patient, the surgeon doesn't need to do a major surgery like what it is needed to be done for a cancer. So that is one thing. Or the surgeon might say, I have removed a cancer, but please tell me whether it is the margin is clear or not, because sometimes the patient, the doctor would want to finish the surgery then and there, other than the pathologist telling the surgeon, oh no, there is tumor at the margin, so you might need to go back and operate the patient again. So basically frozen section is done to get a rapid diagnosis, a rapid tissue diagnosis. So what exactly happens is the specimen is taken from the operation theater and fresh tissue without any formaldehyde is sent to the laboratory. So what we do is, again, the process is the same. Cut the tissue, take a small part of the tissue which we feel is abnormal, and put it on these small things. These small things are known as chucks. So what we do is we put something on it. It is known as the embedding medium, and place the tissue on that. And what we do is place it in this cryostat. So this basically acts like a mini freezer. What it does is it freezes the embedding medium, and this tissue sits on this embedding medium, like how instead of wax, we use this here. So if in a normal histopathology, we use wax to make the tissue sit in the cassette, here we use this frozen ice. And then again, after it sits on this, the tissue is cut into thin sections. And again, it is stained. We use the rapid staining method here. And we see the tissue under the microscope, and the diagnosis is informed to the surgeon over telephone. So this overall, all of it happens over a period of less than half an hour. And all this while the patient is open in the operation theater and the surgeon is waiting for the diagnosis from the pathologist. This is quite a stressful part for a pathologist in the day of a pathologist when a frozen section comes, because you need an immediate diagnosis and you can't afford to go wrong, because the surgeon will base the decision, the further management, on what you say, and you do not have enough time to think and make a decision. So you need to be really sure of what you're telling the surgeon, so that no harm is caused to the patient. So that is what this frozen section is about, and many hospitals in Bombay have this. It is done commonly in many hospitals, and it is a very good process to avoid multiple surgeries for the patient. Next is few points about immunohistochemistry. So this after the advent of immunohistochemistry, histopathology has progressed like anything. Like in the olden days, it was only the hematoxylin and eosin stage, and now hematoxylin and eosin stain. And after the use of immunohistochemistry, where we use specific antibodies to detect specific proteins in the tissue, we have come across many different ways of diagnosing the tumor. So when you do immunohistochemistry, the cells are stained brown like this. Like if hematoxylin and eosin stains the tissue pink and purple, immunohistochemistry stains it brown. So coming back to breast. So if you see breast tissue, what is the importance of this immunohistochemistry in a breast specimen? So in breast, basically we do 3 immunohistochemical markers for all breast cancers. If you diagnose a breast cancer, you will do these 3 markers, that is ER, PR, and HER2. ER is estrogen receptor, PR is progesterone receptor, and HER2 is human epidermal growth factor receptor. So what happens is if a tumor is ER positive, it will look like this, brownish. And if it is negative, it will not show any brown color. Similarly, PR positive and PR negative, HER2 positive and HER2 negative. So why do we need to do this? If the patient is ER positive, the tumor is ER positive, the patient can be given a drug known as tamoxifen. So this will help in the tumor not coming back. It will prevent recurrence of the tumor. It will give a prolonged recurrence-free interval to the patient. What happens if the patient has a tumor which is HER2 positive? The patient can be given a drug known as Herceptin. Herceptin again has its own uses and benefits for long-term recurrence-free survival. So that is what the pathologist does. Basically, diagnose the tumor, diagnose all these finer things. Whether the tumor is ER positive, whether tamoxifen can be given or not, whether the tumor is HER2 positive, whether Herceptin can be given or not, what is the stage of the tumor, and many other things which are important for the further management of the tumor. It is not that the tumor is out means the patient is treated forever. Further, what the surgeon needs to do, what the oncologist needs to do, depends upon what the pathology report says. Next, I would like to talk a few points about molecular pathology. So what is molecular pathology? So this is an upcoming branch in pathology now. Like, it is not only how the tissue looks like, there are many changes occurring at the molecular level. Because how we diagnose COVID-19, basically we are doing on RNA PCR. So there are different molecular processes. There is PCR, there is FISH, and there is CISH, and there are many other procedures which can be used to detect specific mutations. So as I said earlier, for a normal cell to become a cancer cell, specific mutations have to take place. So what we are targeting on is, there is a lot of research going on to find out what exactly is the mutation in a particular tumor. And is there a way we can target treatment towards that specific mutation so that there is better response in the body. So this is a very upcoming branch, and it is very much useful in lung cancers. In lung cancers, there are 4 specific molecular tests which are done on lung cancers, which are ALK, PDL1, ROS1, and EGFR. So what happens is basically after we diagnose a lung cancer, after we diagnose a tumor in the lung, which is malignant, we are asked to send these tests in the laboratory to a molecular lab. So it doesn't happen in a usual histopathology lab. It goes to a molecular lab because the procedures are different. So what the oncologist wants is to know whether these mutations are present in that tumor, and depending upon what mutation is present, targeted therapy can be given to that cancer, and that can kill those cancer cells in a better way rather than usual non-targeted therapies. So this is how a pathology lab can look like. You have a pathologist sitting in its own office, and when there are difficult cases, pathologists tend to sit together and discuss about it. So this is known as a multi-header microscope. So there is one person who can run the slide here, who can see the slide under the microscope, and all the others can sit and see them together. And all the doctors can give their opinion, what they think about it. As you have seen, it is basically just different forms of a cell, different shades of the cell. So it needs a lot of experience to make up your mind on things, whether this is normal, this is abnormal, what kind of tumor is it. So pathologists basically tend to like to work in groups because it gives more eyes and more opinions, and it gives a better diagnosis, and which helps in better management of the patient. Just to put a few points on digital pathology. So as artificial intelligence is coming up nowadays, the microscope is going away from the lab slowly. From many labs, the microscope is being replaced by a digital screen like this, where you can see the pathologist can see the slides directly on the screen. So the basic process will be the same. You have to examine the tissue, you have to take sections from that, and you have to make slides. But instead of the slides being viewed directly under the microscope, they are scanned using tissue scanners, slide scanners, and it can be seen on the screen like this. So why do we need to do this? What is the advantage? So the pathologist need not be on site to do this. He can do it from anywhere. So if he can work in 3 labs, 4 labs, and he can just see the slides on his screen and give a diagnosis then and there. Otherwise, the slides have to reach the pathologist has to see it and then give a diagnosis. This is easy. These images can be sent to him via email. It can be seen from any part of the world. Just to make life easier, like all other means, artificial intelligence is coming up in pathology as well. So that's all from my side, and happy to take any questions, and hope it was not too much of bombardment for you all.
So thank you, Dr. Prisha Balan, madam. So it was a very interesting topic, and it was very delivered in a very smooth and very understandable way for the student to understand. So I hope student might have understood, and if they have any questions, they are free to discuss it now. Or students can write in chat box also. I can take up the questions. Hello. Students can write their questions, or they can even ask directly.
Was it too much for them to? It's a vast branch, so it's kind of, I had to touch all the points.
Yeah. But you have explained, madam, very well in very understandable language for them.
Yeah.
So I think they have understood everything. So that is why there is no such question coming up. Madam, I would like to ask one question with respect to that Tnm staging. Okay.
Yeah.
Means the way it has been numbered. So how any precise way to number that?
So like, as I said, different organs have different Tnm staging. So in breast, basically the T stage, that is the tumor stage, depends upon the size of the tumor. So if the tumor is less than 2 centimeter, it is T1. And if it is between 2 to 4 centimeter, it is T2. And if it is more than 4 centimeter, it is T3. So that is how we call it PT1, PT2, or PT3. So in the kidney is different. In kidney, if it is less than 4 centimeter, it is 1. And 4 to 7 is PT2, and more than 7 is PT3. So it's a very, it's a different mechanism for each organ, but basically the size and the number of node involvement is how we assess the Tnm staging.
Okay. And it is actually the technology that you have shown, okay, that is embedding a tissue.
Yeah.
It is really very nice. It was the first time that I have seen.
So like even when I joined pathology as a trainee initially, I had no idea that such things are happening in the lab. So it is only when I saw it for the first time, I realized, oh, even I never thought that, how does it reach a slide? So that is how it is happening, is very fascinating. So the technicians do a wonderful job. They are very skilled at it, and they do it, hundreds of blocks are done every day, and they are very quick in it. I mean, there are no errors, and with all the tissue labeled properly. The technical staff is the backbone of a pathology lab. If you do not have a good technical support, a pathologist is of no use. Nothing can be done without a good technical support.
So, madam, one question has come up.
Yeah.
Shira, madam, you want to say something?
No, it's okay. I was.
Excuse me, ma'am.
Yeah.
Yes, Akshay.
Ma'am, can we are allowed to ask questions?
Yes, you are. That's why you can raise your hand.
Okay, ma'am. If the question is a little bit off topic, then it's fine.
Yeah, no problem. If it's related to pathology, if I can answer, yeah.
So, ma'am, there is my friend. So he's having some kind of lumps or so-called pebbles in his groin area and even neck and tonsils area. So he went to the doctor checked and he said it is nothing to be scared. So he thought that it is a lymphoma. So doctor told him to do X-ray of chest and some CBC. So the blood work was fine, and even there was nothing in the X-ray. The result was also fine. But even though those lumps were from like 6 to 7 years, they are not growing, they are not causing any kind of problems, but they are still there at the place. And I think he was saying that he's finding it at other places also. But doctor thought that it will be because of some kind of bacterial infection. But my friend told the doctor that it is not because of bacterial infection, because it is there from almost 6 to 7 years now, and it is still there. So doctor gave him some, I don't know why he gave him antidepressant and antibacterial. But I don't know about why he gave him antidepressant pills. So doctor told him to regularly check the weight, whether he's losing his weight rapidly or not, or any kind of weakness or a fuzzy, you can say. But he's saying that there is there is no problem of any kind of like that. But there are the lump is still there in the both the groin areas under the thyroid and even at the both the side of the neck. But it is small and pebble like.
Yeah. So basically, see if a lump is there and it is of the same size for many years, it is more considered to be a benign thing. It might be a neoplasm. So a neoplasm is a tumor which can either be benign or malignant. So if it is present for a long-standing time, like as you're saying, 6 to 7 years, it is most probably a benign thing. A tumor is a malignant tumor basically will suddenly change its nature. Like if there is a big lump and it suddenly changes in size, it is more common to be a malignant thing. Because this friend of yours has been having these multiple nodes, multiple lesions for a long time, that is why the doctor might have said that it is a benign thing, so you don't need to worry about it. Also, if there is a tumor in the body will respond with, like as he said, if you come to us, if you have rapid loss of weight, rapid loss of appetite, so that is how it is. So if a patient has cancer, many cancers do not present as a proper lump. Like if a patient has an ovarian cancer, like in the ovaries, if there is cancer, the patient wouldn't feel the lump for a long time. The only symptom the patient might have is uneasiness in the abdomen or bloating sensation. So or maybe loss of appetite and all these things. So there are different symptoms that cancers can come up with. So these are the finer points which the doctor has asked him to look for. But if it's a long-standing thing and present since many years, it is less likely to be harmful to the body.
Thank you, ma'am.
Ma'am,
Yes, anything else you want?
ma'am, I have a question. Ma'am, my grandfather has been diagnosed with brain tumor. So when we went to the doctor, he told that you need to do the surgery, but he didn't. Uh, but he didn't give us any false information. Like he said that there is no medication for this. You have to do surgery. So, ma'am, but in surgery, malignant tumors cannot be treated, right? So, how is it possible that he is confident after surgery, my grandfather can be cured completely?
No, it is not like that. Malignant tumors can be removed after surgery. In brain, it is slightly difficult because the brain tumor tissue and the brain normal tissue is not very easily separable for the surgeon when he operates. Because the brain is the kind of tissue brain is, it tends to be intermingled with each other, the tumor and the normal tissue. So there are chances that the tumor might remain, but it is not that it is not possible to remove the tumor. Like I told you, the job of the surgeon is to remove the tumor from the body with adequate margins so that no tumor remain at the margins. And the job of the pathologist is to see that whether it has been removed completely. And as I said, to identify the kind of tumor and to stage the tumor for the surgeon to decide what more treatment needs to be given. So in brain also kinds of tumors, and and depending upon what kind of tumor, the treatment would vary.
Okay, ma'am. Thank you.
Ma'am,
So
one
now
question has came from Varun Pasi. Can all type of malignant tumors be treated in later stages?
No, it depends. Like I said earlier, each organ is different. The tumors in each organ is different, and the management protocols for each organ is different. So here in the UK, the thing is, there is a specialized branch. Even pathologists do specialty reporting. Like we have breast pathologists, we have colorectal pathologists, we have lung pathologists. The treating doctors are also different. The lung surgeons, the lung oncologists. So each organ is so different from the other. The kind of tumors which we see in each organ is so different from the others, and there is so much research going on, for oncology aspect mainly. The molecular treatments and the chemotherapy regimens, everything is so vast now that these have all become specialized branches. And that is how, so it depends. It's all very variable, what kind of tumor you have and how much it has spread, how much, what is the staging. Staging for the patient is given on the basis of the pathology report and the radiology report also. The radiologist also plays an important role to identify to which organs the tumor has spread or not spread. So based upon all these things, the oncologist or the surgeon decides what exactly the patient can be offered, what treatment options are available, and whether or not it is possible to cure it or not.
Madam, there is one more question from Sazia Ansari. You want to ask, ma'am, what about blood cancer? How do we come to know that there is a cancer, and how can different type of blood cancer recognized?
Yeah. So blood cancer basically, if you must have heard terminologies like leukemia and lymphoma. So when you have a lymphoma, you can see it as lumps. Lymphoma is basically involvement of the lymph nodes in the body. So these lymph nodes can be anywhere. If it is seen in the neck or in the armpit, you can feel it. You can feel it as big lumps, big hard lumps. But if it is inside the body, there are lymph nodes inside the deep inside the body as well, around the heart, around the lungs, around the abdominal organs. So if it involves those or lymph nodes, we will not be able to see it, but they would give you other symptoms like excessive loss of appetite, excessive weight loss. You feel general sense of not being well. You will get night sweats, fever, all these things. So that is, when these things come, you will tend to go to the doctor. The doctor will order a few tests. The radiologist will do a few scans and, identify the presence of enlarged lymph nodes. That is how you diagnose lymphoma. So this, again, from these lymph nodes, a small chunk of tissue will be taken and sent to the pathologist, and the pathologist will diagnose lymphomas. The other kind of blood cancer is leukemias. Leukemias is basically liquid blood. When it affects the blood, when the problem occurs in the bone marrow from where the blood is made, and the abnormal cells spill into the blood. And when you take a drop of blood and you put it on a slide, you can see these abnormal cells. So basically it will lead, so there are three kinds of cells in the blood: red blood cells, white blood cells, and platelets. So if you have a leukemia, the WBC, that is the white blood cell count, will be very, very high, or it may be very, very low. So there are again different leukemia and lymphoma is a different branch altogether, a very, very vast and a very difficult branch. So depending upon that, what kind of cells you see, and this again, in this branch, there has been a lot of molecular work which has been going on. So based upon that, you can diagnose leukemias as well. Dr.
Yeah. There's a question from one student, Bhavesh Kumar. He's asking, ma'am, how does colon cancer is identified in pathological lab? Any kind of test to be performed? Means what kind of tests are performed?
So colon cancer generally, most commonly it's seen in older patients. Generally, the trend is above 50 to 60 years of age. So clinically, the patient, most commonly what they do present with is bleeding from the rectum. That is, when you pass stools, it might be blood stained. You might have discomfort in the stomach. There may be change in the bowel habits. Here in UK, they have a screening process for colon cancer where they are sent a test kit at home, and they need to do the test using their stool sample. And if it comes positive, they need to consult the doctor, and the doctor then does a colonoscopy to look for presence or absence of tumor. In India, unfortunately, we do not have a screening process, but still When clinically the patient presents with these symptoms, like as I said, blood from the rectum or pain in the abdomen or sudden change in the bowel habits, like everything is normal and suddenly you feel, I need to pass more stools during the day, or I have severe constipation. There can be constipation if there is a tumor in the colon and, it blocks the colon. So the doctor will ask for a radiological examination, or, they can ask for an endoscopic examination and the tumor can be seen. Again, a small part of tissue will be sent to us, and this will, we as a pathologist, we will be able to say whether this is tumor or not. So again, the grossing process is different. As I showed you in breast, there are different margins for a colon. It doesn't have five, like superior, inferior, medial, lateral, posterior like a breast, but it has different margins. So if there is a portion of colon and there is a tumor in between somewhere, so the top margin and the bottom margin is what is important. So we process it in a different way, and it is, as I said, different organs have different means, but that is a basic overview of how colon cancer is identified.
Any other questions students are having?
I think no more questions are there.
Okay, so students have pasted the feedback link and your attendance link. So you have to fill this link. Meanwhile, one more question, madam, if you permit to answer this. Any type of cancer that can be treated?
Yeah, there are many kinds basically, but like when we were students, when we were pathology trainees, what we were told, like if anybody asks you what cancer do you want, if given a choice, you should always say you should ask for a specific kind of cancer known as papillary carcinoma of the thyroid. It is seen in young people, but it is supposed to be a very, I wouldn't say there's nothing called as a nice tumor, but still it is a kind of tumor which is easily treatable, and the patient, it doesn't come back most of the times. And once the patient has had papillary carcinoma of the thyroid and it is taken out, the patient doesn't need to worry for a long time.
Okay, so student, madam has given a wonderful webinar today and very knowledgeable to you all. And a quiz link is pasted in a message box. So how much you have got it, so we'll able to understand from the quiz. Okay, so you have to attend the quiz in a given time. So after half an hour, I'll be closing the link, and let's see. Okay, so all the best for the quiz. So any other question? Okay, so if any other questions, if coming, so you can post me, message me. I will forward those questions to Dr. Prisha madam on the mail ID. So madam will be able to solve that, and I will get back to you. Okay. Dr. Sheila madam. Hello.
Yeah, it's fine. That's great. Very nice. Hello, 1 minute. Yeah, it was a great session. Thank you, Dr. Prisha. And we can go ahead for certificates. Just please present a certificate for Dr. Prisha. We have a certificate for you, Dr. Prisha.
Yeah.
And
Yeah, madam. I'm just presenting.
Archana Beli, vote of thanks, please. Please
Yeah,
go
madam.
for
I'm just
the vote
presenting
of
that
thanks also.
certificate. Yeah.
Sure, sure.
Thank you so much.
Is it?
Yeah.
Yeah. Okay. So this is a small appreciation given from HK College of Pharmacy to Dr. Prisha Balan madam, which have
Thank you
a
so much.
contribution as a resource person on this webinar. And students have been benefited under this session that we have planned as knowledge session, an initiative to enhance students' knowledge. Okay. And I would like to deliver a vote of thanks for this session. So first, I would like to thank our management, who has always been supportive and who had given a chance to deliver such kind of sessions with highly qualified resource person. And I'd also like to thank Principal Sir, who has always been supportive, Dr. M.N. Saraf Sir, and Dr. Sheila Yadav Madam, who had given me your reference that Dr. Prisha Balan would be the best person to deliver on this topic. So I thank you, Madam. Then also I'd like to thank dear students who had been wonderful throughout the session. Okay, and from your understanding that whatever questions you have put on, so it's understandable that you have attended and heard the session nicely. And last but not the least, Dr. Prisha Bal Madam, it was a wonderful session and an enriching session. Okay, so thank you.
It was my pleasure to be here and share my knowledge with you. I'll be really happy to know that people understand what happens in a histopathology lab. We are always behind the curtains and nobody sees us. So yeah, it's a pleasure for me as well.
Yes. Yeah, so that's why we have taken this topic, right? So that students can also understand that what exactly is happening, and we are wondering that how the treatment can be done, and people are like so many students as they are having patient at their home, right? So they have that's why once this session is there and they could got the answer also of their confusion, whatever they were having with doctors and pathological system and all. So this is mandatory that we must share such knowledge and among students, so they will get the idea and they can guide. As we are pharmacists, we are so there for the service for the patient, right? So we should be able to.
हेलो, आवाज नहीं आ रहा है, बंद हो गया क्या?
Maybe madam is disconnected.
Okay, so I think madam, we can end up with the session. Madam has just, I think, got disconnected.
I think she got disconnected. No problem.
Okay, so and students have answered the quiz, and most of them, the quiz was actually of 5 marks, so most of them have got 4 or 5 like that. So they have understood the topic.
So they have been hearing it, listening to it.
They have been hearing and listening. Okay, so thank you once again, madam.
Thank you so much. Thank you for having me. It was a pleasure for me as well.
Okay, so I think we can exit now.
Yeah.
Okay, bye madam.